Good morning. This is the best part of the meeting for me, the opportunity to make the introduction before the presidential address. My name is Steve Schweizberg, and I am the president-elect. They say that Ginger Rogers did everything that Fred Astaire did, but she did it backwards, wearing high heels. Joe Buyske did everything that every other Sage's president did, but while handling two sets of twins and having her house almost burned down, and she didn't miss a beat. In fact, she actually picked up the pace. She helped us mature as an organization that is willing and able to give back to the world community through her humanitarian efforts that this society will carry on. Joe is now the Associate Executive Director of the American Board of Surgery, but prior to moving to the board, she was the Chief of Surgery at Penn Presbyterian Hospital of the University of Pennsylvania for a decade, where she focused on minimally invasive surgery and diversity issues in the surgical workforce. So I guess being blonde is a form of diversity. Joe has done an extraordinary amount of work for Sages even before her presidency. Here's Joe, hard at work. And she's been a member of the Executive Committee and the Board of Governors for many years. Here she is leading the board, serving as the President-elect, Secretary, Second Vice President, and Chair of the Public Information Committee. She's a tough chair. She's been on multiple committees, including program, finance, bylaws, fundamentals of laparoscopic surgery, legislative awards, publications, continuing ed, the state chairs committee, and often keeping us out of danger. She was the program chair in 2004 meeting in Denver, which you know was a lot of very, very hard work, and here's Joe at very hard work with other members of the team. She is thought around the world for her imaginative and forward thinking. Here she is with our Japanese colleagues and leaders from around the world, and her willingness to share her medical skills as well as her sense of humor. She is the consummate family person, and she brings that unique perspective to everything she does, and you can see it in her leadership style with her late mother and her sister. Joe never slows down. She is always in high gear, and it's hard to keep up with her sometimes. She never says no and is always willing to help out a friend or multiple friends. She appreciates what's important and brings that to everything that she does. She's not only been a colleague, she's been a friend, a mentor, and it is my pleasure to introduce our president and my friend, Joe Buyske.
Well, thank you for that very nice introduction and some of those startlingly private pictures. Early last week, I got an email from Barbara Buyske letting me know that at that point, 30 of our SAGES attendees and family members had signed up for the SAGES Habitat for Humanity. 15 more for the blood drive, 18 for the bone marrow testing, 20 to bring books, 22 to bring supplies, and more than 20 people to mentor local high school students. We'd issued a call, and more than 100 people had promptly answered, volunteering time, effort, even their own blood. More of you signed up on site. I'm so proud and glad to be part of this group. Today, I'd like to broaden our view, heighten our consciousness of all the good work that we do, and all that needs to be done. I hope I can reinvigorate those of you who may become tired or discouraged, and remove obstacles for those of you for whom the momentum of inertia or the overwhelming obstacle of unfamiliarity has hindered you from doing all that you might want to do. As humans, we're impelled to do good. Our biology demands it. Our babies can't run like those of horses or buffalo. They can't swim like turtles and fish. They can't even lift their own heads. So we care for them, even at risk to ourselves. We care for our elders. We sign up. We text donations. We give blood and paint schools. We regularly, reliably, predictably respond in ways both large and small to those in need. We do it because it feels good. On PET scans, our occipital frontal cortex lights up when we do something selfless. Our pleasure centers are engaged. Themes of service resonate throughout history. I first heard the phrase, "of those to whom much is given, much is expected," when I went to a Spider-Man movie with my kids. I thought it was amazing that such a profound statement came out of a comic book movie. And I was a little embarrassed to find out later on that it was actually John Kennedy who used it in an inspiring speech. And later still, I discovered that it came from the book of Luke. The power and resonance of that charge, the rightness of it, have not diminished across a variety of settings or over the last 2,000 years. As surgeons, we have the great good fortune of work that allows us to go to bed every single night knowing that just by doing our jobs, by maintaining our livelihood, we have fulfilled those high expectations. We have taken care of people. We have improved their lives. We have done good. How lucky are we? We should pause for a minute and savor the great good fortune, the luck, the wisdom, the hard work that led us to a profession that is so fulfilling. As surgeons, we also need to acknowledge that the reward for our work and effort is a living wage. It's a roof over our heads and food for our children. We have a right to expect that. We have a right to get that. But we don't have a right to more. The more is gravy. The more is excess. The more is lucky. We should be grateful for the extras, grateful for being in the top fraction of a percent of incomes in the country and in the world, and we should be wise with our gifts. We must be good stewards of our skills and our good fortune. As our Japanese friends and colleagues can tell us, our fortune and status can't be taken for granted, is not guaranteed to be with us even tomorrow. Today we have the opportunity to be of service because we have much. Tomorrow we may be in need, or we may find more opportunity to serve. Throughout the world and here in the United States, there are big discrepancies in access to surgical care. According to the World Health Organization, worldwide, there are over 234 million major surgical procedures done annually. The richest 30% of nations consume 3/4 of those procedures. The poorest third of the world's population accounts for only 3.5%. Our ethical human society cannot continue to tolerate that disparity. Basic surgical care ranks with vaccinations and antiviral medications in terms of cost effectiveness and impact on public health. It is primary care, although only recently recognized as such by the World Health Organization. What happens if there's no surgeon? Small curable cancers become large and incurable. Tumors erode through skin and fester. Easily fixed broken bones lead to crippling. Mangled limbs from car accidents, farm accidents, factory accidents lead to permanent disability, infection, death instead of simple amputation. Burns and skin injuries turn into chronic weeping wounds, making productive life, family-sustaining work hard or impossible. Trauma, major cause of disability throughout the world, disproportionately affects people of an age to work for and care for young children. Delayed care or no care causes a ripple effect. The household providers and caretakers can no longer fulfill their role, and an entire family is at risk. If that happens in multiple households, an entire community is at risk. Much of non-surgical primary care can be provided by non-physicians, even by non-healthcare professionals. Responsibility for screenings, weigh-ins, nutrition, vaccinations, and a variety of other services can be shared with people outside the formal healthcare system. There is no substitute for a surgeon. Our skills cannot be delegated. They can't even be delayed. In rural areas in the US, in our inner cities, in developing countries, there just are not enough surgeons to meet the basic needs. In the poorest nations, there's often no opportunity for medical school or for training after medical school. Those with the assets and the ambition to become surgeons go abroad. Many of them never go home to practice for reasons that are all too understandable. Because even if there is a trained surgeon available, and very frequently there is not, there are additional challenges around personnel and resources. The WHO has a tool called the situational analysis to assess emergency and essential surgical care. It's used to document the availability of resources and the ability to do common or necessary surgical procedures. A 2008 study applied this tool to 132 hospitals in 8 countries, including Liberia, Mongolia, Afghanistan, Sri Lanka, and Sierra Leone. The hospitals were district-level health facilities, 50 to 100 beds, 1 or 2 functioning operating rooms. They were hospitals identified as locations where emergency surgical and anesthesia interventions can and should be performed. In this set of hospital, it turns out that only 21% of them always have oxygen, 50% of them always have water, 36% of them always have electricity, and 32% always have anesthesia. Looking at it another way, in 23%, water was never available in hospitals that were dedicated as regional resources for surgical care. The obstacles are impressive. Those numbers won't surprise those of you who've worked in less fortunate countries, and yet even if you're prepared, even if you know these things ahead of time, let me assure you that if you were trained like me, as most of you were, and practiced like me, as most of you do, you'll find these situations challenging, to say the least. I was disconcerted and surprised by something as simple as finding out that I had to pick, choose, unwrap, and lay out all my own instruments in a small hospital in the rainforest in Chiapas. I picked and flipped my own suture material, figuring out not just which sutures, but which needles of the ones that were available I needed to use. And I was actually not prepared for that. I was prepared to have everything I needed handed to me, dropped into place when I held up my right hand. Honestly, I had no idea that needles came in so many varieties. I never had to think about it at my home hospital. My preferences were on my pick list. They were delivered to me seamlessly. In Chiapas, I gowned myself, I gloved myself, I set up the mayo at the back table, and I handed myself most of the instruments. It takes a different part of your brain to do this part of the preparation, a part we're not used to using in our more resource-rich operating room environments. In Haiti, the first day, there was no gauze or sponges, which I discovered as I rolled a burn patient back to the operating room for debridement. So we used blue towels to wrap his wounds. The next day, we started late because at the beginning of the day, there wasn't any anesthesia tubing. Later, we pulled the previous day tubing out of the trash and used it again. I was frequently taken by surprise. As I started to transect the stomach during a gastrectomy, I asked for suction and found there was none. I hadn't thought to ask. There's a lot I forget to ask because our operating rooms make it so easy for us. On the island of Bohol, the OR tables were so low that I operated kneeling. In Chiapas, the electricity went out so frequently that we only did vaginal hysterectomies in the afternoon when the light came down low through the OR window. In Mozambique, the problem of erratic electricity was solved by having somebody ride a stationary bicycle to power the generator during the rare emergency cesarean section. As far as I can tell, there actually never is good OR lighting. Battery-powered headlight, priceless. I can recommend a few. You might have been surprised at the WHO statistic that 23% of the district hospitals never had water. And so was I when in Haiti the scrub sinks dried up the second day, and on the 40-person surgical ward there's not a single sink. In Chiapas, there was water for the scrub sinks, straight from the stream that ran right alongside the property. If you go, do not brush your teeth with water from the tap, because that's also supplied by the stream, and shower with your mouth closed. If you go, in managing these situations and working with them, you'll benefit. You'll think hard about what you use and why. You'll apply flexibility, using a different instrument or instruments of different sizes than you might have expected. You'll be frugal. You'll think about each step of the procedure, what exactly will be needed in terms of instrument and people. You'll revisit surgery in a way that you may not have visited it since medical school or residency. You'll be exhausted and refreshed. I know I always am. In January of this year, we sent out a survey to SAGES members asking about their volunteer experiences and kicking off an effort to match willing SAGES members with organizations that need surgeons. 110 SAGES members filled out that online form detailing their experiences in international service. They described everything from teaching to doing hernias, thyroid surgery, rectovaginal fistulas, 25 cases a week, 50 cases a week, 400 cases in a month, trauma, cesarean section, laparoscopic cholecystectomy, circumcision, bladder stones, esophagectomy, gastrectomy, burns, hysterectomy, orthopedics, splenectomy, and non-surgical primary care. Some of them went as the only surgeon, others went with teams of general surgeons, groups that included gynecologists, plastic surgeons, or urologists, and still others worked with local surgeons as part of a team to collaborate, learn, teach, sometimes to tackle harder cases together. The list of organizing agencies was long and diverse. Universities such as UVA in Nebraska, humanitarian groups like Doctors Without Borders, Aloha Medical Mission, and of course SAGE's own programs, the international proctoring courses through the Global Affairs Committee. The US is not immune to shortages and discrepancies in supply and care. There are vast areas with no surgeon where people have to travel hours for treatment of their disease. Pause and think about the reality of that. Needing to drive 4 or 5 hours more to seek treatment, to have a friend or partner come with you, to have your family need to stay in hotels to visit you if you stay in the hospital, the cost in terms of money and emotion and time that's laid out for even the most minor of surgical events, not to say a major surgical illness, perhaps with complications. In rural areas of this country, the practice of surgery is different than it is for most of us. It includes some orthopedic surgery, fractures, carpal tunnel, some GYN in the form of hysterectomy and cystectomy, and lots of endoscopy, that field of surgery upon which SAGE was founded and continues to excel. It includes taking into consideration that all of the services needed for a patient may not be available without a long, long journey, and the complications of referrals, phone calls, and arranging transportation. It includes a lot of call. It includes the need to meticulously arrange coverage long in advance to come to an educational meeting like SAGE's, to learn and to share and to meet people. In our cities, there are lots of surgeons, but they're not necessarily available to everyone who needs them. Hospital insurance screening mechanisms prevent uninsured from having even the most basic screening or testing, sometimes even from making an appointment. Safety net hospitals have long waits, aging facilities, setting up a dual system of care, often quite close by to a better resourced hospital. State licensing, CMS regulations, and the dependence on other services and specialists make volunteer work within the specialty of surgery in this country difficult, but not impossible. Our survey of SAGE's volunteers turned up 23 members who volunteered domestically and included agencies such as FEMA, the Crohn's Colitis Foundation, Ambulatory Surgery Access Coalition in San Francisco, the National Health Service, and MedWorks, run by our own Buyske family in Cleveland. Some of our members have made the long-term commitment for service to both our country and to individuals in other nations, both those at war and at peace, by volunteering in the military. The impulse to service has always been part of our surgical culture. It's why we do what we do. We all wrote about our desire to serve or the need to care for others in our medical school and residency essays. Don't pretend you didn't. I know that you did. It's exciting and heartening to see a new energy behind that urge. Our SAGE's volunteer service included a site for members who wanted to volunteer but had not yet done so. 159 SAGE's members filled out that form within a few days. Medical students going into surgery now ask about the opportunity for service rotations when they interview at residencies. It used to be that students interested in service chose infectious disease or pediatrics. Now they see that what we have to offer as surgeons in all parts of the world is unique and critically necessary. Until recently, international rotations were frowned upon and were not allowed credit by my own shop, the American Board of Surgery. And I'm happy to report that thanks to the hard work of John Tarpley from Vanderbilt and Tom Whalen from Lehigh Valley Medical Center, the chair of the Residency Review Committee, that the ABS and the RRC jointly agreed to allow international rotations that fit specific, wisely developed criteria, mostly around supervision and safety. Our surgical residents will have learning experiences that transcend surgery. They'll learn and provide care, and they'll see their own great good fortune differently. SAGE's as a society also has a commitment to service at multiple levels. Our Global Affairs Committee, led by Dr. Horacio Asbun, runs a tightly developed program called SAGE's International Proctoring Courses, which teaches laparoscopic cholecystectomy at mid-level hospitals in developing areas internationally. Courses have been offered in Peru, the Philippines, China, Cape Verde, and Nicaragua. We contribute locally at our annual meetings as well. We've long been careful to use centerpieces that can be donated to local retirement homes, and our food excess is given to local food pantries. Yesterday, we had a Habitat for Humanity event, and today, after these talks, you can give your blood or register for bone marrow donation. In the hallway, you'll see a drop box for books, and another for instruments, and yet another to recycle your meeting shoulder bags. Here's the thing. Find someone who did one of those things, who donated blood or books, went to Habitat for Humanity. The secret is that the donor is not at all depleted, that they're invigorated, they're refreshed, they feel valued and valuable. In giving, we get back, and that feels good. If you're one of the folks who participated in the 2011 projects here in San Antonio, speak up and let your friends know how good it felt. If you didn't have a chance, ask someone who did. They'll tell you. Ask the people whose faces you see on the screen, or whose name you see on the list of experienced volunteers who responded to our survey. Play the scavenger hunt at the main event tonight, and meet people who've done all kinds of service work, both in medicine and outside our specialty. In giving, we get back. We fulfill our charge as members of this great worldwide community. As Americans, as surgeons, we have a special charge. Of those to whom much is given, much is expected. So what more then can we do? You'll each have to decide for yourselves, but I have the privilege of speaking for SAGES, and I'm proud to say we have new projects under development. The Humanitarian Task Force, headed by Dr. Tonya Young-Faddock, sprang out of our fall leadership retreat and had their first meeting this week. They're hard at work identifying new service opportunities. If you have done service work or are interested in doing so, you'll find a registry on our website that details the experiences that other SAGES members have had, including contact information for programs that seek surgeons and a frank discussion of what you can expect as reported by your colleagues who've been there. Our Global Affairs group will have trips to Mongolia and China and will transmit educational lectures to Haiti, where a new, well-equipped hospital will have laparoscopy and thoracic surgery capabilities. SAGES is in early discussions to help develop an organized teaching program there, building on our experience with fundamentals of laparoscopic surgery and our SAGES International Proctoring courses. Now I'd like to take a couple of minutes, actually, to recognize some of our SAGES members as my personal allies, my guides, my inspiration, my friends. I know it's going to make you uncomfortable, but I always need to feel part of our community, so I am asking, as your Madam President, I'm going to request in the strongest possible way that you stand in the audience and stay standing when you see yourself pictured, because I'm going to be watching you, and you're going to have some explaining to do later on if you don't do what I ask. The first is David Ratner, past SAGES president, now president of our sister society, the SSAT. I've known David longer than I've known anyone at SAGES. He was my attending, later my mentor, and for many years now I've been proud to call him my friend. His impishness and easy laughter mask his wise leadership. Lee Swanstrom, who had enough faith in me to make me his program director at the SAGES meeting all those years ago. His thoughtful, open, and inquiring mind is always inspiring, not to mention his rather startling vehicular courage when we traveled together in China as part of a SAGES team. Steve Schweitzberg, my partner in crime, you can sit if you want, the president-elect, the one who always had my back and shared my vision. Sir, we look forward to your presidency with high expectations and great anticipation. Sally, whose calm wisdom and effective, I know she'll do what I say, and effectiveness permeate all aspects of our society. My friend, I'll miss our regular contact. Barbara, SAGES mama, who will never take credit for anything, was at my first committee meeting and has been right with me ever since. Thank you for making my hazy visions of service activities in San Antonio a reality. Jeff Ponsky, whose easy humor, relentless optimism, and innovation never fail to inspire. Jeff opened the door to national leadership for SAGES when he became chair of the American Board of Surgery. Brian Duncan, leader in endoscopy, diplomat, creator of this year's spectacular out-of-the-box program. Brian made this year easy for me and great for all of you. Nat Soper, whose easy, low-key, laid-back leadership I try to emulate. It does not work all that well for me. I'm a little too tightly wound for it. Mark Talamini, who for years preached the gospel of SAGES value in national surgical education and helped to establish us as the educational force to be reckoned with that we are today. I'm going to let you sit, but not yet. As pictures continue, I'm going to ask each of you to stand when you see yourself. I wish I could talk about each of you individually, but I can't. I can't comment on all of you who make SAGES in this year and the future years possible. We're looking at a partial list of my special allies. This work, these accomplishments, have all been made by our volunteer army of committee members, board members, executive committee members, and other volunteers. This year we had 368 people working on SAGES projects. Some, like FLS, range over a decade and require hundreds, if not actually thousands of hours of work. Some are short and effective, completed in the course of a year or a single meeting. All require time away from home, from work, from family. SAGES at its core walks the walk of service, in this case service to our profession, to the patients who benefit from our work. I'm so proud to be part of this community and humbled by the honor of serving as your president. As a society, we've accomplished great things. We've developed the field of laparoscopy, innovating and broadening applications, improving accessibility and patient safety, and forever keeping our eye on training. We've developed new endoscopic procedures. We've collaborated with industry and academics, with other specialties. We've thoughtfully engaged and explored other new technologies, robotics and notes. We've developed leaders in American surgery who now command a world stage and we've reached out across our own country and other continents to teach, to learn, to share. These amazing volunteer professionals who've made this work possible have each contributed to SAGES in ways that had special impact on me, either as presidents, leaders, senior advisors, members of the executive committee who give so much, young and brilliant Turks, loyal workhorses, all good friends and excellent dinner companions as we meet in various venues around the world to do the work that makes our society so strong. I thank each of you, and many whom I can't picture here. You have inspired me, supported me, and enriched me. For those of you who stood, thank you. And you can sit down. So I'm not done. I have two groups I still need to acknowledge. First, my family. My sister, Donna, you have to stand up too. She overcame her fear of flying to come here today and overcame her fear of flying and blood to come assist me in the operating room in Chiapas. I thank her for her years of being my friend, my confidant, my companion, and my consultant. Joseph Friedberg, my husband of 20 years. We met as residents, and over the years did dozens of operations together. He is a superb surgeon. If unexpectedly and unhappily you find yourself in the midst of bloody mayhem in the operating room, there is no better person to have across the table. Joe was always genuinely surprised when I faltered or had self-doubt during my surgical career. His confidence in me lifted me across many barriers, and I thank you. My children, Amelia, David, Gabriel, and Dashiell. I'm so glad you're here with me today. Your resilience and openness and generosity of spirit are inspiring. You've cleaned parks, served in soup kitchens, packed boxes of food, made sandwiches, worked with autistic children, the elderly, donated your money to Heifer International and the Virginia Institute of Autism, and done these things so routinely you've barely broken stride. You've tolerated my late nights, my bloody shoes, and my compulsion to travel to faraway places. My hope for you today is that you find work and passions that are meaningful for you, and that you better the world in large and small ways. And I hope I've made you proud. So since this is SAGES, we have to have a video. I'm going to show an amateur clip of our SAGES Far East singing, "We Are the World." I'm going to ask our Japanese colleagues in the audience now to stand and to remain standing for a moment. I've known for a year that I wanted to incorporate this performance into my presidential address. Our colleagues from Japan come to our meeting to share their experience, to teach, to learn at SAGES every year. And in spite of the horrific disaster that's ongoing in their homeland now, many of them are here. They're part of our community, and as many of you know, they highlight our main event. The song they close with has become our SAGES anthem. It invokes the best of us. I ask again for all of you to stand. I didn't see anyone stand. And I'm glad in closing to share it with you now. I hope you can all see in that celebration, in that coming together what I see. We share a community of service, we rejoice and we thrive in it, and in giving we are renewed. Of those to whom much is given, much is expected. We can all fulfill that charge. And thank you for the honor of serving as your president.
There are very few opportunities in life to be inspired. That was terrific. For those of you who are SAGES members, now you know why you are here. For those of you who are not SAGES members, I hope you can see a future in front of you. This plaque is given to Joe Buyske, our president. It reads, "The leader has to be practical and a realist, yet must talk the language of a visionary and idealist." Those words are written by Eric Hoffer, who lived from 1902 to 1983, and I think they capture the essence of our president, Joe Buyske, and it is my pleasure to present this plaque to you in recognition of your service as our president. You want to introduce? She has one more or two job to do.
So it gives me great pleasure to introduce our next speaker, the Gerald Mark Lecturer, Dr. Cam Wright.